This is the MRI of 18-year-old boy who has right side radicular pain from hip to the lateral malleolus, not extending to the foot, laterally only. This is
स्मॉल नीडल भाई एक छोटी सी सुई लगेगी हाँ ठीक है so you see here the facet is more toward the middle side so I'm not going to go more laterally I will go more centimeter so you see this is more of a central herniation and in central herniation you need to be exactly go to the center okay so make a skin wheel which should look like more of a big wheel so we don't have a problem so this is a combination of the 1% lignocaine and 0.1% bupivacaine okay and then now I will just put the needle so now he is okay I just pass the needle like this my trajectory will be toward the center of the disc and now I will just start and inject with the local so now so this is we are doing in the pure local anesthesia so we have to be very sure that this will just go this will anesthetize the entire tract okay and then I can just proceed picture so picture so you can see I am going to on the upper side I will just try to start with the tip of the SSD picture I think the second I can feel the bone so I know the target not at the lateral view so you can see my tracking will be little up and down so that I will confirm so initially you always keep some angle so that will help you because you go inside the disc and then you can work on the disc so you have to reach to the area from where the disc is migrated so that will be subannular area which will be little free area so now we will just confirm so I have just put the local anesthesia fine picture okay little more down never okay so now you see I'm on the facet but I still have to go a little more deep so it's okay I'll just try to go like this I'll just try to change my angle picture so you can see I have just crossed the facet and now this is only 1% lignocaine because I don't need a long acting so now I'll just cross the facet now I can see I can feel I'm on the annulus you can confirm I'll just put a small drop of okay now I will go inside the disc I will inform him थोड़ा दर्द आएगा हाँ so now you see this is inside the disc confirm so I will put a little lignocaine also थोड़ा आपका दर्द आएगा तो बताना है ठीक है देखो दर्द आया अभी
दर्द आया बोल
आया आया ज़्यादा आया so you see with lignocaine 1% I am doing the provocation because of the pressure so you see now lignocaine has also worked here and now I will just take so you can see this is the lens should go without any problem so confirm picture okay so you see it's always better to be on the lower part of the spine picture and this is the stem so this is how you take a stem line so you see the entire thing is comfortable, and this guide wire should be free. Now with the rotatory movement, so this is a special 20 millimeter tapering dilator. So this will just make your entry very easy. You can see picture. Okay, so you have to be sure about the guide wire. The guide wire should not go across. Picture. Okay, so now I will just try to change my guide wire because I have crossed the picture. So now you see, I can change it a bit. Picture. So you see here I have option picture to change my direction. Okay, so you can see I can change my direction. This is going toward the center of the disc. थोड़ा दर्द होगा. Picture. Okay, so now I am inside the disc. Now you can see the angle. Okay, so in 80 you should confirm where exactly we are going. Okay. And you see this is a bevel and this is toward the bevel side, and this is I can just go inside. बस थोड़ा पता चलेगा. Okay. So you see we are in the center. So this is the exact position, and this is my target. थोड़ा अभी पता चलेगा. हाँ. So this is the only painful part for the patient, but with some fentanyl and with patient. देखो आप पैर नीचे रख दो, कोई प्रॉब्लम नहीं है, हो गया अभी. हाँ 2 मिनट लगेगा बस. सॉरी बस हो गया. Picture. Okay. So you can see we have already reached to the. ठीक है. हाँ ठीक है. So now you see this the fragment.
ये निकल गई देखो आपकी.
क्या निकल गई?
So you see this can happen because you see the disc fragment will push more to the nerve, but this is okay. So now I can just pass the camera. So this is the first picture of the endoscope. Irrigation on. So this is the irrigation. So you can see this is the scope. बस सर अभी जुड़ा नहीं है. So you can see we are exactly inside the disc, and now I can work on the disc fragment. Hold it. Sure. So this is the grasper. I will just try to clean this material. So you can see this is the disc coming out. You see this is a big chunk of the disc come out. So you see this was actually flashing the patient. Now he will be more comfortable. So now you see this is all the loose disc fragment which we can take out. So you see this the disc on the L-4-5 was more on the left side, but since the patient was clinically more symptomatic on the right side, so I decided to do on the right side. And now you see this is also the X-ray. Come. So you see you just try to take out the loose fragment first. So what will happen? Now you see this is the epidural space and this is also annulus. Okay. Picture. So you can see now the annulus and the PLL. So this is called half in, half out technique, where So now what I will do, I will just cut some part of the.
बनाते हैं। वीडियो बनाना सियाम थोड़ा पीछे नहीं है?
No. Yeah, I need to keep on checking the here, so you can come up or down. So now you see, I'm just trying to see. You can see this is also the three sides segment, but you see this was all red. Okay, so that is the main herniation we already removed. Now we just have to remove the. So you see, unless you don't remove this fragment, you will not be able to exactly see the structure nicely. So this is come after the experience, because the most important for me is our patient. Now you can see this is all the big fragments are coming out. Especially the young patient, the disc will be so soft. The first fragment which came out, which was very big, and it was not really soft. कोई एक को इसको पलट ना पड़े, ठीक है, लेफ्ट साइड ये एंगल पे so you see, this is all I'm feeling. This is all I'm feeling. It's like this grasper is like your finger. You can feel by your hand, then you know what to do. This is what exactly I'm doing. I'm staying away and I'm working subannular area, and then I'm just trying to go more straight. So like if you see my scope position, so you see this is also the big piece. I can feel in my grasper it's coming out. So now you see, go close. You see, I'm using this 15-degree grasper. So 15-degree grasper is actually aligning my uh, working with the scope, because this scope is 30 degree. Now I will just work on this area. The smaller grasper are better because you can actually see. Now I will just look towards the foraminal area. So you can see now the epidural space is quite free. So you can see the epidural space. So slowly I will just try to create a small subannular area, free, and then you can just grab the herniation. You see? So being more on the subannular area is the key. So you see, since he is a young patient, I don't want to remove much of his annulus. I don't want to even cut much of his annulus. Now I will just go and just check if we have done is enough working or not. Now you see, this is my movement. So now you see, there will be a lot of question about the adequacy. So you see, like this is comes by the experience, and I don't believe in removing all the structure, especially for the young patient to see the root or something. But you see, this is like we are inside the disc, and when we have removed the enough fragments and herniation, then you see this is the movement of the epidural thread. So like this is a transmitting impulses. So once you feel and you see that okay, these epidural impulses are quite good, and once I feel there is nothing in between my so once you feel that your decompression is adequate, so this is completely on my tactile sensation, and this is the most safe way, and this is most safe for the patient also, because you are always working inside. So like you see my movement like this, I will just try to see if I'm holding something. Yes, okay, okay. So this is I'm going to get it. So then gradually the pulsation will become more and more free, and then finally I will just check and see the final decompression. where there is a herniation. Okay. So you can see my movement. I just go like this and then I open the jaw. Okay. So you can see this other. So actually this kind of fragment I actually feel. So this fragment goes from here to the spinal cord, spinal canal. So you have to grab the tail. Once you grab the tail, I'll just open the. You can see this is the tip coming out. Okay. So you see this is almost my filling in my scope. So you see this is technique which I have developed over the period of years. The reason is this is very good. We can say it's annulus preserving discectomy and without much damage to the disc. And most important, what you can feel and appreciate is the amount of the bleeding what we are getting very less. So now you see this is getting more and more free. So it means the compression is already relieved. Okay, so you can take PRP. So now I feel this is okay. Yeah. So normally we like to use PRP after every discectomy. This will serve three purposes. It contains growth factor, so it will give you the very good relief in the post-operative pain. It will help to regenerate the disc, and since it contains the platelet, even it's also important to heal the disc as well as initiation of the coagulation. So it will also control the small ooze.
Young patient.
So young patients, like you see, you can easily and you see the most important here, there will be again a debate about the adequacy. But for that you have to get the experience, and especially some of the people say that I want to see the nerve or something. So then you have to do a lot of work, which is actually not helping the patient, which is actually creating the problem for the patient. So this experience I have after doing almost 5,000 transforaminal surgery. So you see, now with my forceps, my instrument, once I remove certain amount of the herniation, now you see the place is quite free. Okay, I'll just use a quarter little, only 20. Okay. So you see, these are all the small combination of the disc and the annulus which we are removing. But you see the working on the below the annulus area, it's always safe. It will save you from the most of the complication, and it also makes your job more easy. So again I am telling you, these are the small fragments which are coming. So I am just using it my jaws in my finger to exactly know it is happening. Okay, you can see now. You see, these are the fragments. I am taking it out from my jaws, feeling. Okay. And now I'm searching for any free fragment. So like you see, the successful discectomy by transforaminal is not only to remove the herniation, but remove all herniation as well as all possible herniation which can come out in future. Like you see now, you can see the epidural space is quite pulsatile. Now see, okay. So this is a sure shot sign for me. But again, I will just look for the any possible loose fragment. So now I can see this is all part which is quite free, and the root area is also free. You can see this is the area for the 1 o'clock, 2 o'clock is the fitting root, and you always check this area below the pedicle. So if there are some fragment or something, you can always work like this. So especially this guy is having more of a traversing root pathology of L-5 root pain to the right side. So I think this should work very nicely for him. And to me, this discectomy is adequate for him. Sometimes the small foraminal bulbs are there which you may miss. So like I'm just checking it here, and I can see these are the small fragment I'm removing. So now you see this area also, 3 o'clock area. So this is the area for foraminal area for the exiting root. So you cannot see the exiting root, but from pulsation you can make out. And you see this one was also there. Okay. This we remove from the foraminal area. This is red. This is a little hard. This is going to have a good impact on the outcome. So you know this is a learning curve. What you have to get. to achieve this kind of result success. And now you see, I will just try to clean this area. So now I will only use the radio frequency probe. And now again, like with the forceps, with the feel of the forceps, I'm just trying to get my movement. I'll be able to know. You see, everything is very okay. So you see, you always have to keep on checking the free fragment, because what I believe is this will get degenerated and it will become fragmented. So like all the fragment which you can take out is good for the patient's outcome. So you see, my movement is not dangerous. I am just going and I am just rotating like this. This is, I am also taking a little hard part of the annulus also. So this annulus, once you remove, will help to regenerate the new annulus, which will be much stronger. But this is a degenerated annulus. So you see, absolutely there is no need for doing further X-ray. So I'll just check. You see, right now we are in the foraminal area. Okay. Now I'll just go again. Picture. So you always take a little like this, and you go inside. This is a safe picture. And you can see when the patient is awake, so you don't worry, and then you just push it. Now you see here are two pages. Now check how it is. Okay. So this is the opposite area where but we already removed that part. So now this is a check scopy. So like this is the opposite area. I'll just try to remove this all three fragments here. See the disc which is into the fragment, it is not attached with the parent disc, and that is not useful disc. Okay, so that's why you have to always have to remove those discs which is free. This part of the disc which is soft, and when I am trying to pull it out, it is not coming out. So that is like attached disc. So we are not worried about those discs. So now you see, if I will come out, I will just try to see. To me, the most important disc which is here is something you have to look for. So you see, initially when we started, the angle was like this, and now you see the angle is different. So like you realize we are gradually becoming flat. So this will take you more toward the posterior epidural space, posterior to the annulus. So now you see this is the annulus, this is annular defect. Okay, from where the disc bulge out. These two annulus are on the side. And you see this is also coming from the opposite side. This was also big. Okay, so you can see this is the annulus and this is the just below the annulus, and I can see this is free. Okay. So you see, sometimes if the defect is big, you have to be careful that you should not pull out, because then in that case, sometimes this root also the cord comes out. So you have to be careful while doing this. So now you can see this is quite clear. Okay. This is the epidural space above. This is the annulus or TLL. And this is small. Okay. Now you see this is the freely pulsatile annulus. So I'll just cauterize it from inside. Now you see this is something you can look like. This is the disc herniation. This is annulus. This is TLL and the epidural space. And now you can see everything is free. So you can see all 4 parts. You can just do a small cauterization here. Right? So if I hold everything, you will be able to see the nerve pulsation. So inside. Okay, so this is done. I'll just stop the irrigation from here, and I'll put PRP from here. So the PRP will go inside and it will take the place of I'll just put it with the needle. Here is the final nail. So you can see this is what we have achieved, and we are happy. And like for those who are not doing the transforaminal endoscopy, they will always like have the question but once you do it, you realize, and this is a PRP which we are injecting inside. So I can confirm X-ray. So this is L-4-5 discectomy. So we are going to do L-3-4 also. So we can stop now. Thank you.